E agora não sai esse troço daqui. Ah, não acredito. Aquela hora eu consegui, mas tinha saído, né?
Se tinha clicado ali do lado.
Tá gravando já?
Sim, já está gravando. Quero dar boa noite a todos que estão assistindo ao vivo. Quero apresentar para vocês a doutora Renee. A Mayara, ela vai apresentar um pouquinho melhor. Ela é a nossa intérprete. Está fazendo o papel de tradução ali simultânea. Certo? Nós vamos estar transmitindo, então, ao vivo. Estamos transmitindo ao vivo daqui do auditório da Aramed, onde estaremos fazendo algumas práticas aqui com as pessoas que estiverem presentes junto ao auditório. Uma capacitação para dar uma introdução, na verdade, sobre esse aparelho que nós estamos tentando trazer para todas as unidades de suporte avançado de vida aí do SAMU de Curitiba e região metropolitana. Então, antes de mais nada, quero agradecer a disponibilidade da doutora Renee, agradecer ao doutor Michel Cadenas, que é o diretor da Pro-Ativo, que nos ajudou muito na elaboração dessa capacitação. Ele não mora no Brasil, doutora Renee, ele mora na Europa, e inclusive nessa semana ele está aqui no Brasil, mas ele consegue fazer a gestão de lá. Então, boa capacitação a todos. Doutor, quer a palavra?
Desejo boas-vindas a todos e que a gente possa aproveitar e, de repente, essa nova tecnologia possa entrar no nosso serviço e a gente possa aprimorar a assistência aos nossos pacientes. Sejam todos bem-vindos, uma boa capacitação a todos. Obrigado, doutora Renee, pela disponibilidade.
So Myra, I just typed it in. I'm actually just seeing it in Portuguese. I'm so sorry. So if you don't mind, just I assume a little introduction, and we have the professor here. Anything else I need to know, or should I just go to it?
That's okay, no problem. Nelson and Professor Michael Cadenas, they were welcoming you to the meeting and saying that we are very happy to have you here. So we hope that everyone can learn a lot this night and have a very good training meeting with us right now.
Thank you. So I would love for anyone to interrupt me with questions at any point in time. Myra can help out if needed. What I want to do is provide some foundation. So ultrasound can be scary and intimidating if you didn't learn it in school. And so I want to really try to help make sense of it with you all. Hopefully this works. If not, my friend, Dr. Ana Claudia Tonelli, is in Porto Alegre. She's an internal medicine doctor, and there are some other great ultrasound people around, so we could try to set up an in-person training if I fail. So, but fingers crossed, we do good. So I'm going to show my, I'm going to share my slides here. And hopefully you are seeing this pre-hospital ultrasound. And I don't see you all anymore. So Myra, just give me a yes if you can see my slides, if you don't mind.
Yes, we can see your slides. It's perfect.
Perfect. Do you see my little black cursor moving around the pre?
Your black?
The cursor, the little...
Oh, yes. We can see perfect. The cursor. Yes, okay. Sure.
Right. So as we mentioned, it's my pleasure to teach you about pre-hospital ultrasound. I work in the hospital, but I have friends around the globe, friends in Slovenia, friends in Kenya who've done pre-hospital ambulance ultrasound. So I know we can do it, and I'm excited to try to teach you all. So at the end of this today, I hope that each of you will be able to define point of care ultrasound. POCUS is a term we throw around, but I would love for you to be able to say what it is and why it's special. I want you to be able to list 3 use cases for POCUS in your pre-hospital patients. So 3 different things that you can do to change your patient care before you get to the hospital. I want you to know how to use the VAVE ultrasound device to obtain the images yourself. And this takes practice, but I want to get you used to the foundation of how to use it. And then I want you to be able to recognize badness, so abnormal findings in the EFAST. So we're going to talk about the EFAST protocol. It's just one protocol. There's many others, but I thought this was a good place to start. So we're going to make sure you can recognize some pathologic findings on the EFAST. From there, I hope you are able to practice and learn more and see if we can integrate it into your practice to take good care of your Brazilian counterparts. So first of all, what is POCUS? Hocus pocus. What is point of care ultrasound? So this is my university, Oregon Health and Science University. It was built up on top of a hill. So they put these little gondola or tram cars up to it. So this is where I work. And what is POCUS? So I realized this wasn't the perfect image because you all might not have Lucas devices. So let's just say a standard cardiac arrest patient with or without, however you're doing it, a patient in cardiac arrest. So here you can see the secret sauce. The special part about POCUS is the clinician at the bedside, real time with their patient. And they are getting images. And you can see he's looking over here. He's interpreting the images and he's integrating it into his patient care. So that's the secret sauce of point of care ultrasound. You, paramedic, nurse, doctor, nurse practitioner, anything, you're getting the data, interpreting it, and acting on it to advance your patient care. So let's take this cardiac arrest example. We can see my patient already has some fluids hanging. So I'm pumping in fluid, but what are my questions? So is there a reversible cause of cardiac arrest? Is there something we can fix? Who knows? Maybe you're an hour out. Is there something I can reverse in the moment? So traditionally, you might listen, get an EKG, not in a pulse, look to see, do a rhythm check to see if it's shockable. You could, if my patient had a pulse, I could check for a pulsus paradoxus, not in this case. So we might listen, but really our CPR and we're kind of blind. Versus our POCUS, I'm going to look for a tension pneumothorax. I'm going to look for tamponade or a pericardial effusion. And I might also, as I get more advanced in my skills, I might look for a giant blown right ventricle that might suggest something like a pulmonary embolism. So I'm going to get that data real time in between pulse checks. So you can get it from this view in between pulse checks, or this, I can look for my pneumothorax while compressions are going on. So for our usual care, we might do our best hunch and enact whatever plan of care for what we think is going on. With our POCUS, if these things are negative, I'm going to focus on my other H's and T's. But if it's positive, I can do needle guidance. I may say, I really think this is a pulmonary embolism, etc. I'm just an internal medicine nerd. I work in the hospital. So this is much more your skill set. I'm just trying to provide some examples and hopefully a new tool that you all can learn. Myra, is this pace and everything going okay? Are we doing all right?
I think yes. Nelson, tá tudo bem? Vocês estão conseguindo entender?
Perfeito.
Excellent.
Perfect. Yes, Renee,
Okay.
everything's perfect.
Thank you. So, as I mentioned, I work in the hospital, and this is where POCUS started. Maybe you're in the emergency room. Does this patient have hydronephrosis or not? And before, we would order a test. A sonographer or maybe a radiologist might get the test. That if it's a radiologist in Brazil, then they would read it and give me the report. Versus in the US, it's a sonographer that does the image, a radiologist reviews the image, and I get a report. I then have to clinically integrate it into what my patient has told me and my other data. So it's like a piece of a puzzle. But with POCUS, again, resource limited areas, pre-hospital, in the home, I'm able to gather data real time and act on it now. So I like to say, to be competent or to be good enough at POCUS, you have to be able to do three things. You have to put on your sonographer hat and actually get the images. You have to have the technical skill to move this device and get an image that is useful. And then you have to have the cognitive skill or the pattern recognition to interpret it. To me, this isn't harder than an EKG at all. Pattern recognition, ST elevation, pattern recognition, black fluid around the heart. To me, this is no different than an EKG, a radiograph. It's just another thing I'm interpreting. And then the last and most important piece is my clinical integration. And so I have to know, as a clinician, what I want to do with that data. What if my patient, let's say they have liver failure, cirrhosis, and they always have ascites. They always have 3 liters of free fluid in their abdomen. And they're a trauma patient, and they are hypotensive. Finding a positive FAST exam with fluid in the abdomen might not mean blood in that patient. So that's where the clinical integration, what is your pre-test probability? What did you find? What are you thinking now? So these are our 3 POCUS pillars. And to be good, you have to practice each of them. You have to practice hands-on. You don't just magically wake up and learn it. And we could do cases or other things to work on image interpretation. And clinical integration just comes with practice and time. If you're able to learn with a group, like your group of clinicians there, or a partner, you can bounce ideas off of each other, or do a case conference where you share what you saw, what you did, and learn from it. Many ways to keep learning. So that was our point of care ultrasound. Here forward, I'm just going to call it POCUS, okay? So I now want to make sure there's like a million things you can POCUS. You can POCUS the eyeball. You can ultrasound the sinuses to look for sinus fluid. Obviously, you don't care about that in the ambulance. You can look at the gallbladder. There's so many things you can do, but then it gets overwhelming. It's too overwhelming to think about everything you can do. So I want to keep it focused for you all. And so we're going to talk, I'm going to make sure we can recognize at least 3 use cases. So we already discussed this here, our paramedics. So we could look in the case of cardiac arrest, we can look for some of the H's and T's. And then what about non-cardiac arrest? Just regular patient with dyspnea or hypotension or a trauma. So fluid is black. Again, fluid is black or anechoic, no echoes. So this here, this is black fluid above the diaphragm. So this is a pleural effusion in this patient. Another nice one that is focused and nice, is my peritoneal fluid. So this curvy thing here is the diaphragm. This is my spleen. When the patient breathes, I see a little bit of splenic vessels in there. And this is black fluid. This patient happened to have, I think this was a cancer patient or cirrhosis maybe. So this wasn't traumatic fluid, but just an example. And then finally, pericardial fluid. So here's our liver up here. I'll talk through how to get these views. The heart is beating, and then we see this black or anechoic fluid around it. Again, you all know this, that pericardial effusion does not equal tamponade. Pericardial effusion is fluid, and tamponade is, of course, a clinical diagnosis. And again, we're back to the third pillar of clinical integration. One of the questions I'd heard from Myra and Nelson was, how do we make sure we're doing it right, etc. So focusing on yes, no, fluid, no fluid, keeping my question very focused helps. And then always remembering your clinical skills anyway. If you hear a muffled heart in a patient who's hypotensive, maybe it's a huge fat pad instead of pericardial tamponade. So I do a lot of teaching for medical students. So I'm sorry if I'm overemphasizing the clinical integration. I just don't want my students to go out and make the wrong call. Ultrasound by itself doesn't hurt anyone, but we all know doing the wrong thing for our patient can. So those are 3 additional ways we can use POCUS at the bedside. As an internist, I do this bread and butter all day, every day. Shortness of breath is so incredibly common. So now we're going to talk about how we actually use the VAVE ultrasound device. So I have re-downloaded my app, and I'm going to show you exactly how it would be if you picked up the probe, got the app, and started fresh yourself today. And then we're going to talk about how we use ultrasound itself, ultrasound as a technique. So I'm going to show you how to use this device and then the concepts of ultrasound overall. So I'm going to, what I'm going to do, oh yeah. So this part is back to our image acquisition. This is our, how do we actually get the images that I then can interpret? So I'm going to stop sharing my slides. And then what I'm going to do is I'm going to share my screen and I'm going to show you my phone. So I'll show you what I'm doing on my phone. So let me figure out how to do that. I'm going to do the window. Here we go. Okay. Okay, so you should be seeing, oops, that was not the right one. Let me try this again. There we go. Do you see, are you seeing a phone screen?
Sim, nós já, yes, we can see your phone screen.
Okay, perfect. So the VAVE Health app is this one down here. So when you first download it, you'll get, we would set people up with accounts if you all end up using it. So the app opens and it's going to have me log in. So I'm going to log in and then it's going to walk me through some cool stuff. So while I'm logging in, so on the device, there is this little thing right here. Oops, sorry. And this is the power button. So I'm going to push and hold it for 1 second. And a little blue LED light comes on. this light turns green when it's ready to connect. So I'm going to set it down for a minute and log in, and then I'll show you. Okay, so it's logging in. I wanted you to see the full process. And we can see here, this little light is now green. So that means it's ready to connect. So what I do is I hit this Start Exam button down on the bottom. And it's going to walk me through some things I need to, because you can see there's no cord here. So it needs to transmit the data without a cord. So it uses Wi-Fi. So we're going to say Start Exam, and it's going to prompt me. It needs to be able to find devices on my network. So I say allow, and it's going to tell me I have to grant permission. So I'm going to tap this right here, and it's going to say, allow it to use your location. This is for the Bluetooth part of the connection. So I'm going to say allow while using app, the middle. It's funny, it didn't show up for you all, but, and then this Bluetooth permission, it's going to say grant permission. And, oh, there it is showing up. Okay, so yes, I'm going to let it use Bluetooth. So it walks me through it. And now it says you have this available probe. So I'm going to tap on this probe. And it asks me, this is for my medical students when I have 20 students in one room with 20 probes. So we have this favorite, saves your favorite probe. It doesn't matter, but I do it. I just say save and Start Exam. And then it says it wants to join your Wi-Fi network. And so we're going to say yes. And I'm going to put a little bit of ultrasound gel on this probe here. And so you're going to be seeing the screen on the left, my phone, and the ultrasound has to have gel to transmit the ultrasound beams into my body. Otherwise, air is the enemy of ultrasound. So right now, I'm not seeing anything. Let's put on this gel, and now I'm going to see an image there. It's not anything in the image yet because it's just the air, but that's our image there, okay? So that's how we connect it. Down at the bottom left here, there's something that says presets. So instead of having words, English, Portuguese, whatever, we have these little pictures. So for instance, I might say, I want to do abdominal. For the EFAST, I would want abdominal. So I'm going to tap on my little liver here. All right. So from there, I'm ready to ultrasound. I'll talk through some of the parameters. So here, I'm going to swipe up and down. And as I swipe up, you're going to see that my depth changed to 21 centimeters. If I swipe down, my depth is going to change to 7 centimeters. Maybe my patient weighs 300 pounds and I need more depth to get to their kidney versus maybe I have a 6-year-old that's very small. And then brightness or gain is something I can do left to right. So it's left to right. And this is making, it's kind of like the volume on your radio, kind of turning up, amplifying the volume. Okay. A couple of other things. If you were doing this for SAMU and you wanted to get feedback and review later or send it to the doctor at the accepting hospital, what we can do is down here, there's something called capture. It looks like a little camera. So I could capture a still image that's just like a photo, or I could hit record here, and record is going to do a clip. You can set it to 3, 6, whatever seconds. So just to show you, we're going to go through how to do the EFAST, but I would love to show you how quickly it can be done with some practice. So I'm not going to, I can do the full thing later if you all want to see it. I'll just show you one view quickly right now. So we're going to pretend I was in a car accident and I have left upper quadrant pain. And so I'm going to put the probe on right here. And I'll show all of this in slides later too, but I just wanted to show a real example. So I'm going to put my probe on and we're going to look for my spleen, and I made it too shallow. See how it's 8 centimeters? So I need to increase my depth. And there I'm going to see something. This thing here looks kind of like a peanut M&M. That's my kidney. And then my spleen is right up here. And so I can see the space in between the kidney and the spleen. And then if I take a really big breath, I'm going to see lung get in the way. So lung, blow it out. If I had hemothorax or blood in my thorax on the left, I wouldn't see that air. I didn't quite go as deep that way. So this will make more sense after I've shown you some of the slides, but I just wanted to show quickly how it's quite fast. It's also why I'm wearing a t-shirt for you all, so I don't goop business clothing. Okay, so that's the connecting, turning it on, scanning. And now I'm going to stop sharing this window. Later on, if you want to see a full eFast, we'll do it. And now we're going to go back to sharing my other window. And it looks like a couple of questions or comments, 412, 413. Are we all good with those? Did I cover those? Just give me a shout if not. So we shoot back to my screen. Are you seeing the 3 POCUS pillars again?
Perfect.
Great, thank you. Okay, so we're going to move on to ultrasound basics. And these concepts are the same, whether it is a $200,000 machine that your radiologist has, or the couple, $2,000 machine that you have. So there's different types of transducers. I showed you this one here, and there are more in the pipeline. So I want you to know why you use which transducer. For the eFast, you're perfect entirely with this one here on the left. This is called a phased array device. This one here is the next one we'll be releasing for VAVE. And then this one here is out a ways. So again, this is called phased array device. It's got a small footprint. So the footprint is what touches the patient. So this is perfect because it's great to go in between the ribs, and it's good for the heart. Low frequency means that it can penetrate deeper into the body. And so this is really an excellent probe for our organs. So this thing here, this is an example of a heart, and the beam comes out almost like a piece of pie or a triangle. So we have this small little footprint, and then the beam spreads out. And again, it's so good to go in between the ribs and in the abdomen. This is excellent for the heart, the abdomen, and the lungs. You can also absolutely do obstetrics with this if you have an OB call. In the US, obstetrics is a huge place for lawsuits. So I don't know how much y'all would want to do, but you could certainly look for fetal cardiac motion. So again, the phased array device is perfect for these things: heart, lung, heart, liver, abdomen, lung, obstetrics. The linear probe This is another one you might hear of or you might see used in the emergency department or elsewhere. So this has this wide footprint, so it gives you a nice big field of view, and it's high frequency. I like to tell my medical students, high frequency is like high definition television. So if you all are watching soccer on a high def TV, you can see all the little blades of grass and everything. Versus low frequency is lower resolution. So it penetrates deep into the body, but it doesn't give as pretty of a picture. So this one really high frequency, high def, but you can only see what's close to the surface. This is an example of, this is the thyroid, and this is a carotid. This is the trachea here. You can do all kinds of crazy stuff with a linear probe, like ultrasound guided cricothyroidotomy and wildness. But this is the beam. It's this kind of rectangular. This is what you would do central lines with, or peripheral lines as well. So this is the next one on our roadmap that we're hoping we'll have soon. So it's ideal for shallow things like vascular. It's great for lung sliding, but you can also do lung sliding with this one. And in an emergency, you often don't have time to change in between. So the EFAST uses this probe entirely. Okay, so I already showed a little bit of this, but let's look at what depth and gain do when it comes to your image quality. So again, depth, right down here on the lower left quarter, 23 centimeters. Yesterday, I was up at OHSU, my university, teaching nursing practice students to look at the kidneys and the gallbladder. And so many of them had an image like this. If I'm trying to look at the kidney and it's squished up here, I don't get a very good view. But watch what happens as we reduce our depth, and it's getting bigger and bigger. But then if I go too far, oops, I've cut it off of my screen. So if you wanted to see fluid deep to the heart and you cut off the back of the heart, you would miss it. So you want your depth. You don't want to waste the screen space, but you don't want to cut it off. And again, in our app, that is finger on the screen, up and down. Okay. Gain, that's what I mentioned. It's just like turning up the volume of the signal. So ignore that boring quote. So watch what happens. We're going to swipe to the right and it gets brighter, and swipe to the left and it's going to get darker. And then we'll show a kidney and what happens when we change our gain. If, let's say this is a trauma patient and I'm trying to look for free fluid in the right upper quadrant, this is too dark. I can't see anything. So watch what happens as we increase our gain. Okay, so now I'm able to see liver versus kidney, but if I go too far, I actually can't see very well either. So the device, the preset, puts you at the good gain for most patients. But we know there are very skinny patients and very heavy patients. There are patients with liver cirrhosis where the liver will transmit the beam differently. So you can adjust your gain, but I tell people don't mess with it too much, because that is just too much there. You can't see anything. One other thing is that when learners are starting, they're tempted, they get a bad view and they're tempted to turn the gain up. But we have to think about the angle. So ignore all of the text and just look at this right here, this red. If I am not at a 90-degree angle, I lose my beams. They reflect off. I can only see what comes back to my ultrasound probe. And so here, if I turned the gain all the way up, it would still be an ugly image and it would be too bright. Instead, I could move my probe to get at a 90-degree angle, and that will give me a better image instead. Okay, so we're making it through more of the conventions here. I'm going to take a sip of water. So every device, every transducer or probe, again, from your $50,000 GE all the way down to the VAVE, they're all going to have an indicator on it. So for us, it's this white button or white piece. So what this does is it corresponds with the mark on the screen. This lets us get the same images the same way, the same orientation every time, which makes it easier for muscle memory, and also cognitively, it makes it look the same every time so that my eyes are better at picking up the abnormal fluid, for instance. So it corresponds with that mark there. And we use the same convention that the sonographers do. So when we're doing an abdominal image, our ultrasound beam is always going to be, or our marker indicator is going to be toward the head or the patient's right. So here it is towards the head. So we're seeing here an inferior vena cava running through. And so when I was learning, I would stop. The screen sometimes gets confusing. And I think, okay, if my indicator's towards the head and this is my indicator, that means that this is my patient's head. And this is my patient's feet. And this is my patient's skin. And this is deep. And then I look at my probe and I say, okay, deep is out the back. So it's kind of like anterior, posterior. And so here we have those labeled: head, feet, front, back. So this helps you as you're learning. If you orient yourself the same way, you know what to expect. So that's for our sagittal planes, sagittal or coronal probe marker towards the head. Now, when it's a transverse, probe marker is going to be going towards the patient's right in our abdominal preset. And so here, this is an aorta. This is a superior mesenteric artery and stuff you don't care about. But so probe marker here. And that, again, if I think about it, this goes here. So that means this is the patient's right, patient's left, their skin or anterior and posterior. And this means that if your coworker is standing, let's say you're out at a scene and someone's standing over your shoulder, they can look and know and say, I don't have to see my student's probe. I can see on here and I'll say, slide to the right, slide to the left. So when we do it the same way every time, it helps us all in interpreting it. Okay. See if you flip it here and you do it backwards. So if this is the correct orientation and you're trying to show me the far right of the patient, I would tell you, okay, I need you to slide right, right, right. But if somebody holds it backwards, I'm looking and I think it's going towards the right. So I say, okay, slide left, left, left. So that's, again, we do the same conventions every time. So one thing I didn't tell you is that the cardiac preset in the United States, this little indicator is over here and it's flipped 180 degrees. But we're not going to worry about that because today we're just focusing on the EFAST exam and we're going to keep it in our abdominal preset because we don't have time to switch probes or switch exams. We're keeping it in our abdominal preset.
Just a minute, Renee. I have a question here.
Yeah.
They're asking if we can see the peripheral and central venous access. Is it possible? Can you show us if yes?
Yeah. So When we get back to scanning me, I will show you what it looks like. Because this is the phased array probe with a smaller footprint and lower frequency, this device is perfect for heart, lungs, abdomen. It's not good for peripheral and central lines. Our next generation will be, but this is kind of our workhorse for the internal organs and EFAST, cardiac, trauma, etc.
Ela, rapidamente aqui, ela disse que esse não é um aparelho, a melhor opção para acesso venoso nem periférico nem central, mas sim para órgãos como pulmão, fígado, coração. A próxima geração dele terá essa opção, mas esse aparelho especificamente não seria o melhor para acesso venoso vascular. Thank you, Renee. Sorry.
Of course. No, please stop me anytime.
Okay.
Okay. So we've learned how to turn on the probe and how to hold it, how to change the depth and the gain. But now we have to try to find what we want to see. So there are different movements that we can do to try to see what we want to see. We call them the cardinal probe movements. So I'm going to show you examples of all of them and what they do so that you know when you're trying to find that kidney or aorta, you know what to do with this. A lot of times in the beginning, learners will kind of do 4 movements at once and have no idea how they got there. So we try to break it down into 1 movement at a time. And then what we might do is after we cover these, Myra, you and Nelson can ponder if you want to do a break or just keep going. So, but I'll keep going while you all think about it. Okay, so sliding is a lateral translational movement. So I'm just sliding on the skin. So here's an example. I have ribs, and if I wanted to see the space in between, this looks like a spleen to me, that's in the kidney, I would need to slide my probe down a rib space to get where that view is, okay? So I could tell my student, slide 1 rib space towards the head, or slide your probe towards the back. So this is, again, just kind of our translational movement. So we'll see a real clip here. So this is just an example. So here I'm sliding over rib spaces to try to see the kidney, for instance. So that's an example of sliding. So we like to call this window shopping. I'm sliding to find what I want, and then I want to lock into the window. I want my footprint to stay. So I slide to where I want to be, and then I want to lock it in. I often tell my students to hold down low, like you're holding a pencil, and then put your pinky or your hypothenar eminence on the patient so you don't slip off with the jump. So sliding is our window shopping. Next, we have rocking. Let's see a video of this. This is an end-to-end movement. Come on, little video, you can do it. There we go. End to end is our rocking. Think of this like a rocking chair. So end to end. This is the curvilinear probe showing you what rocking looks like. And so we basically use this to change our angle end to end. So watch what happens as we move our beam. So let's say my aorta is right there, kind of on this right side of the screen. That's the red thing. And I'm rocking and I'm moving away from the aorta. Oh no, I wanted to center the aorta. So let's rock back this way. So let's see a real example of that. So again, aorta. This is where my aorta is. And then if I rock it, I'm moving it across the screen and back across the screen. So rocking is kind of moving things left to right on the screen. When we have something in long axis, a longitudinal structure, rocking then can flatten it out. Let's pretend I wanted to measure this width right here. Say I'm outpatient primary care and my patient smokes 2 packs of cigarettes a day, and I want to screen for an abdominal aortic aneurysm. This angle is not going to be the best to measure front to back here, anterior posterior. So I'm going to rock back the other way to really flatten it out. And so we'll see another example of that here, a clip here. So rocking is our side to side movement. So you can imagine we can slide left to right, or we can rock it left to right. So those are two methods to move things across my screen. So again, across our screen, we use it to center and then to change that angle. All right, so number 3, fanning. This is my favorite. Think of it like fanning myself with a paper fan, for instance. So fanning is like the slices. So we're gonna, oops, sorry. I'm hitting play too fast. There we go. So fanning is along this long axis. Excellent. Okay. So the beam of our ultrasound, the width of the beam is super, super, super thin. I tell my students, it's like thinner than a piece of paper coming out of here. And so I only see what is directly in plane with this. So this is like the thickness of that beam, right? And if I needed you to tell me there was no fluid in the hepatorenal space, I would need you to fan back and show it to me. So we fan, I'll say fan posterior, fan anterior, etc. Sometimes my students will get frustrated because they see bowel in the way and they're trying to see the kidney. And I say, if you can see air, your beam is too far anterior. You need to fan that back posterior to get down to the kidney or the spine here. All right. So this is fanning here. We are showing, we're going anterior posterior. One thing that we show you is that we're over a rib here. So this rib is kind of like getting in the way. So sometimes if I fan, I'm fanning onto a rib. So we have to keep that in mind. But that we're going anterior, posterior, or it doesn't matter, you know, fan towards my head, fan towards my feet, etc. Here's a nicer angle where we kind of locked in and then we fanned. We didn't slip over the rib. So this, you're getting to see that nice kidney there. So think of this like the CT slices of ultrasound. It's just like the slices, you know, transverse slices or whatever, but you're controlling it. You're controlling the slices. Okay, we're almost done with this, I promise. So our rotating is just simple clockwise, counterclockwise. So we're just changing. We keep it locked in one position. We found what we want, but we want to see it at a different, like maybe an orthogonal plane, 90 degrees. Sometimes we'll say one view is no view. So that's our rotating. So here I am pointed probe marker or indicator towards the patient's head. And so this is that, let's say, a long axis of the aorta, versus when I've rotated 90 degrees, I'm now giving me the short axis. So rotation is clockwise or counterclockwise, either or, to give us 2 different planes. Here's her, it's my sonographer, Chrissy, showing rotation 90 degrees. And if you remember that that indicator is always either pointed towards the patient's head or the patient's right, you don't ever rotate around to the rest of the way. So there's one trick with rotation. If I want to get on the long axis of something, I have to put it in the middle of my screen. So see this right here, the midpoint, this little white marker is right down over here. But let's say I wanted to see the aorta. So if I rotate, I come down here and I'm totally missing my aorta. So let's see what happens here. So this is showing me the center of my screen. The aorta is not there. And I rotate and I've lost my aorta altogether. So one more time without that center button. Okay. Now, if I want to see the long axis of the aorta and I put it straight down over the aorta, when I rotate, I'm right in that nice long axis of it. So let's see that one here. So I've centered my aorta and I'm going to rotate it and get this nice long axis. And we'll do it one more time without the center. So we're going to center it first, and then we can use this to elongate structures. For instance, the kidney, the superior pole of the kidney is actually a little bit more posterior. So you may have to, if you want a true long axis of your kidney, you might have to rotate your probe marker a little bit posterior. Okay, so the last cardinal probe movement, and then you can figure out, well, let me know if you want a little break or not, is our compression. This is really important for sonographers who are trying to get things like the gallbladder, the abdominal aorta, behind all that bowel. I would say for you all in trauma settings, the E-FAST exam is going to be over ribs mostly. So there's not a lot of place. If you compress over a rib, it's not going to move. So compression is really for the abdominal space. So we could do it for a subxiphoid or a suprapubic, but we just don't want to compress over the ribs or your patients will try to punch you. So compression is just what it sounds like. We are pushing down. And what we're doing is we're trying to get our probe, our ultrasound beams, as close to the source as possible. So we're just trying to get, I'll get a better view the closer I get. So this is an example of the aorta. And so we're kind of moving it down. You can see how far up that aorta moved, and then let's see it without the red dot. So it gets so much clearer and brighter when we get it up here. I'll play that one more time. Much prettier image there. Okay, gotta get off there. So for compression, closer the better. So now we have made it all the way to the E-FAST exam windows. How are you all doing? Is it boring yet?
Ela está perguntando, gente, se vocês estão entendendo, se está tudo bem, se podemos continuar, ou se vocês também querem fazer um intervalo agora.
Eu acredito que daria para a gente fazer ali uns 5, 10 minutinhos só para o pessoal ir no banheiro, para a doutora Renee tomar uma aguinha, né? E daí a gente volta em 5, 10 minutinhos. Tudo bem para todos?
Tá dando, gente, para entender, para acompanhar os slides e a compreensão da aula? Tá tranquilo?
Tá legal, tá legal.
Da minha parte, sim. Tudo certo.
Perfeito. So, Renee, yes, everybody's understanding. I think that the strategies that we use it's working.
Hooray.
So, yes, that's perfect. And yes, we can do a break, like 5 or 10 minutes, just to drink some water, go to the bathroom. You take a break also, and then we can come back. So what time you would like to come back? You can determine, no problem.
Yeah, let's just do, yeah, what do you want?
10 minutes. What do you think?
Aproveite e só relate para ela que nós vamos estar agora mostrando para as pessoas que estão aqui no auditório um pouco sobre o aparelho e depois a gente volta para fazer as práticas. O auditório aqui está cheio, está com mais ou menos aqui umas 46 pessoas, né? Então a gente vai passar demonstrando aqui o aparelho para eles conhecerem um pouquinho, tá bom?
Nelson is saying that they have people there with them at the auditorium, and they are going to show them the probe. So
cool.
during this break, they're going to see the probe, touch them, yes, and then we can talk a little bit more when we come back. So here in Brazil, it's almost 9 o'clock. We can come back like 9, 10. What do you think? 10 minutes?
10 minutes is great. I'll be back and ready. I'm just going to grab more water anyway.
Perfect.
But yeah, I figure, especially because it's so late there, a little stretching of the legs would be good.
Okay, so we'll see you in 10 minutes.
Excellent.
10 minutinhos, pessoal, de intervalo, ok? 9h10 a gente volta.
Boa noite, doutora Isa, tudo bem? A gente está em intervalo, voltamos daqui 10 minutinhos, ok? Só permanecer na sala. Camila, nós estamos no momento do intervalo, mais 5 minutinhos a gente retorna, tá bom?
Diego, I'm going to grab a towel so that I can show them all the fast exam on myself later without being too goopy. So I realized I came back on camera slightly too soon. I'll be right back.
Eu acho que a gente pode retornar.
Ela foi pegar uma toalha, já tá vindo.
Ah, perfeito, eu não escutei ali ela falando.
Ah, não, que ela vai fazer uma demonstração, aí ela foi pegar o conta do gel, né?
Ah, sim, legal. Pessoal que está aí em casa assistindo, está conseguindo copiar bem, está recebendo bem as informações? A tradução tá legal aí? Para quem está com dificuldade, na tela ali do própria reunião, tem uma caixinha embaixo escrito CC. Se você clicar naquela caixinha escrito CC, tem a opção de tradução e qual é o título da reunião. E aí você consegue traduzir a reunião automaticamente ali, tá bom? Dr. Renee?
Okay. Hello again. I will share my screen again.
Qual caixinha, Nelson?
And then we're gonna, so we'll go through, oh, sorry.
Just 1 minute. 1 minute. 1 minute. Há uma caixinha, Thiago, do lado da câmera e do microfone, um quadradinho escrito CC. Se você clicar ali, você consegue fazer a tradução.
Renee,
Ah,
just a
perfeito.
second. It's because there are some participants with some doubts about the translation. So now someone is helping them.
Ah, nice.
Graças.
Foi, Nelson? Todo mundo copiado, então? Tá tranquilo com relação aí à legenda e tradução? Podemos continuar? Okay, Renee, so we can go on.
Excellent. So we are going to talk through the EFAST, and then I will show you the exam, and then we can do whatever questions, etc. Okay, so we should be good again here. So as I discussed before, we have the 3 POCUS pillars. So you have to be able to acquire the images, interpret them, and clinically integrate. So in a lecture, I can't teach you all the way how to acquire them. I'll give tips, and then we'll make sure that you have seen the normal, abnormal. And then my friend Gregor, his name is Gregor Prozen. He does pre-hospital paramedic doctor. He's a MD in Slovenia, and he does pre-hospital ambulance work, teaches a ton of ultrasound. So he couldn't make it today, but I was going to introduce you all in case you wanted to hear some of his real cases of how ultrasound has helped. So, okay. So the EFAST, the E stands for the Extended Focused Assessment with Sonography in Trauma. First, though, there was a FAST exam. So emergency medicine, gosh, this is one of the very early uses of POCUS. So cardiology, babies, and the FAST exam. So in a trauma patient, before CT scanners instead of a diagnostic peritoneal lavage. In ERs where they had the capabilities, they would look for free fluid in the right upper quadrant, the left upper quadrant, the suprapubic space, and the subxiphoid space. And one might ask, how well does the actual original FAST exam perform? I threw in, there's a couple of resources I really like. The POCUS Atlas has this cool part called the Evidence Atlas, if you wanted to look up a specific finding. They also, you can search for AAA and find images that other people have posted. So it's a very nice resource. And then, oops, wrong way. Another one I like, this is a lot of data, but I just wanted to show it, GEL. It's the Ultrasound GEL podcast. And so it's evidence-based. And so this is a nice visual depiction of a study by Vivetta Lobo, who is an emergency medicine doctor at Stanford. And in a retrospective review, when they looked for the most sensitive place for free fluid, it surprisingly wasn't Morrison's pouch, which a lot of us were told earlier. It actually was this inferior liver tip, or the caudal liver edge. So I just thought this was a nice little infographic. So what about the EFAST? The EFAST, the extended, is just covering the lungs. So we're covering for pneumothorax as well. The pneumothorax itself, so no sliding and a lack of comet tails or beelines, performs incredibly well. Better than a 2-view chest x-ray, certainly, and I imagine in the field you probably don't have 2-view portable chest x-rays. So how are we going to go about this? We're going to go through it in the order that they have described it here. I've heard from my emergency medicine colleagues that it will depend on their clinical suspicion. So in a young woman with a positive pregnancy test and severe pelvic pain, they might start in the pelvis looking for signs of a ruptured ectopic. In someone who had blunt force chest trauma and is, thready pulse, they might start with the cardiac, thinking maybe RV perf. So this is, if you're coming at it open, this is another great website resource, POCUS 101. You could do 1, 2, 3, 4, 5, or you can be guided by your suspicion. So for one, our right upper quadrant. So this is an example of the space we're trying to interrogate. So as you know, our images show up like this. And if you recall, if my probe indicator is towards the head, that makes this the patient's head, the patient's feet, the skin, and deep. And in this case, deep is slicing across, the bottom is actually towards the spine. So this is a normal right upper quadrant view. But because we're used to kind of thinking of patients upright, we're just going to twist this a minute to show the anatomy together, and then we'll flip it back. So this is so that you can see the colorized anatomy together. So here's our liver and our liver. This bright white is our diaphragm. The lung shows up above it. It's called a mirror image artifact. And then we see the kidney down here. Okay. So Morrison's pouch, this is the nerdiest fact of the day. Morrison is spelled with 1 R, not 2 R's, which it's a ridiculous fact that I like to tell people. But Morrison's pouch, or our hepatorenal space, is this potential space. Normally, the liver is just sitting right on that kidney, but it's the potential space. So where can fluid go? We can see fluid or blood in the lung base, in Morrison's pouch, and again, down at that inferior or caudal liver tip. So to do this, we start indicator towards the head, as we've discussed, kind of mid to slightly posterior axillary line. The liver is a big, beautiful window. And so generally, some people count ribs. I don't really do that. I just kind of plop it on the side, maybe around the bottom costal margin. And this is another kind of cross section. My beam is slicing in. And so we're trying to interrogate this dependent space for free fluid here. So again, we have to, if we're too far up, we can fan our beam posterior, or you could slide a little bit and also fan your beam to try to get to where there's fluid there. So here is that right back upright again. So again, we have our kidney, liver, diaphragm, and the lung is up here. It's this mirror image artifact. It looks kind of like the liver. And now we're going to contrast that one with this one here. So notice how I don't see black fluid around here, but I do see black fluid here above the diaphragm. And I know it's above the diaphragm because we know that it's the head and the feet. If my probe is pointed the correct direction. So again, we see this black fluid here above the head. This is the other example that I put in the earlier slides. This is more fluid here. So this is black fluid above the diaphragm. And there's actually, you can see there's a tiny bit of black fluid in between the diaphragm and the liver itself too. So sometimes we see fluids in multiple places. And again, I'm an internist, so my patient that has severe heart failure is probably going to have fluid in the lungs, fluid around the lungs. Sometimes they have cardiac ascites. So fluid has a differential diagnosis, of course. So that was our looking for kind of hemothorax. Now, what about within the abdomen? So the liver normally is butted up against the chest wall. And so as I fan here, we can see there's black fluid around the liver and kind of sneaking up here. We like to say free fluid is pointy. It's pointy versus the bladder, the gallbladder, the vessels are contained and more rounded. And so again, oops, sorry. I want to contrast. It doesn't want to behave. Okay, well, this one here on the left is a normal again. And then the other study that we talked about was talking about the one we were mentioning, that you have to see that inferior liver tip and that there's no anechoic or black fluid above or surrounding that liver tip. So now let's look at this one over here, and we're going to see just the smallest bit of fluid over here. So does a small amount of fluid, is that clinically relevant? I don't know. You're there with the patient, their vital signs, everything else. The awesome thing about POCUS is you can do it again. You can do it again in 10 minutes, in 20 minutes, in 30 minutes if you have a long transport. So you can see what's evolving as you go, or if you're not certain, just look again. So again, fluid up there at that liver tip. Okay, so that was our right upper quadrant. Now our left upper quadrant. In most patients, the spleen is smaller, so it's a little bit harder of a window, and it's also tucked back up more posterior. So for this one, we will tell people to get their knuckles to the bed when they're holding the ultrasound device to try to get posterior. So again, it would be head, feet. So we're just going to rotate this so that we compare the anatomy together. So it's looking at it the same way. So we have our spleen here. The spleen and the liver look very similar. Liver just has additional blood vessels. We've got our kidney down there. We've got a psoas muscle. Actually, you can see sometimes when you're nice and posterior enough. We've got our spine. And we didn't call out on this one, the diaphragm. And then the lung would be superior to that. So probe marker towards the head or indicator towards the head. Sometimes we have to go even further towards the head and posterior. Just depends. My favorite teaching doctor said patients are like snowflakes. No two are the same. Perhaps for Brazil, we'll say grains of sand. No two are the same. So again, slicing through, this is our beam. We've got our spleen and our kidney, and we're making sure we really interrogate that fluid space. One thing that's important to know is that there is a ligament between the spleen and I think it's the splenocholic ligament. I think, I'm not a surgeon. So fluid, I have to look between the spleen and the kidney, but also I have to look between the spleen and the diaphragm in the left side. So the subdiaphragmatic space as well. And so speaking though of superior to the diaphragm, this is an example here of we have this anechoic or black fluid surrounding this lung versus over here, it looks speckly above the diaphragm, just like that. So normally it looks kind of, we see a mirror image above it versus abnormal fluid transmits those ultrasound beams. And I can see the spine and this black fluid. So down in the abdomen itself, again, we have to look for this subdiaphragmatic space here. So we see, I'll pause it for 1 second. It's just at the beginning there, we see a hint of the diaphragm. And so unlike this one here, where when the patient breathes in, I can see that spleen goes up to the diaphragm. Here, I have fluid between the diaphragm and the spleen, and sometimes it curves around underneath here. So let's look over here as well. This is a different one I have. So this is tons of fluid, and you can see that nice, beautiful diaphragm. There's actually a little bit of fluid above the diaphragm as well. And then as we move a little bit here, we can actually see these the splenic like arteries and stuff. Sometimes you can get confused by a large stomach, I will say. So let me come back to this one here. This right here, it's this kind of like bright with a shadow behind it. It looks like gas. This is either the colon or the stomach. And a huge fluid-filled stomach can look black with maybe some bubbles, but it would be in here. And again, free fluid is pointy. This fluid is pointy and kind of curving around both ways. Again, this fluid here is pointy and coming down under versus the stomach would be more walled off and circumscribed. Okay, so we've done our right upper quadrant and our left upper quadrant, and now we're working down to our pelvis. So just a review of so this is a sagittal. So the bladder lies low. So if you have an obtunded patient, of course, you can scan that low and it will be fine. If you have an alert and awake patient, I like to warn them. The bladder sits very deep. So you can say, you place your hand over your pubic bone and I'm going to rest my hand on yours, or just let them know. But it sits right behind the symphysis pubis. So just zooming in a little bit here, this is our area of interest. probe marker or indicator towards the head, like we discussed, this is the slice. Sonographers start it with the indicator towards the head. I see a lot of ER doctors start it with the probe indicator towards the patient's right. It's just a style thing. However, you can get it. So this is an example of that sagittal. So in this cross section, the bladder isn't quite rectangular until it gets really full. So the bladder is that black structure. Fluid transmits the ultrasound beams. And then this back here, this is our prostate. And then the rectum or the bowel is back here posterior. And then we also often have bowel up here towards the head or superior. So if my patient's bladder is empty, it's decompressed down below this symphysis pubis and all the bowels are in the way. So again, sometimes you really have to either rock or in the transverse fan that beam way down into that pelvic bucket. And there's that symphysis pubis there. So we look for what it should be is contained fluid is not pointy. It looks like it belongs in something versus this here, there's this pointy fluid, pointy free fluid. I'll pause. Oh, my sharing window is right. Did I? Okay, there we go. So here, this is this free fluid. Notice on this other side, I can't tell where bowels are or anything else. It just looks like a bunch of junk. Anytime I see discrete lines, discrete black lines, or the outline of bowels, normally it's just a mishmash of stuff. So if I can see the outline of bowels as well, that makes me, it draws my eye to it. Okay. So here, now we've rotated transverse. And so we are fanning through. This is the rectangular bladder. The prostate pops in for a second there. And now let's look here. Again, we're fanning, fanning, fanning. And there we start to, again, see this pointy free fluid as I get down in that inferior space. One thing to note is that our iliac vessels sit on either side of the bladder here. And as you fan down, they kind of dive down. But again, you can follow them and see they keep going. They're not this pointy free fluid. So this is an example of free abdominal fluid. Now, how about the female pelvis or the pelvis patients with uterus? Well, I guess not everyone has a uterus. Anyway, so when we have a uterus present, we will see, it just depends on if it's anteverted, neutral, or retroverted. But we're looking for this, the pouch of Douglas is what we're looking for. And sometimes we do see fluid up here as well, but generally it's like this dependent fluid between the uterine space and the rectum. So again, where is our fluid going to track? It's going to come down posteriorly. And so as we fan here, we fan across, and this one has, this would not, and this is again, your clinical reasoning is so important. So there is like the tiniest bit of little black fluid right here. Just yesterday with my nursing practice students, one of them was ovulating and had a tiny little bit of black fluid there. So is there severe pain? Is, you know, what is your differential diagnosis? So it's just something to keep in mind. So I happen to think that the bladder is so much fun to ultrasound. So this one here, I'm going to show you, it starts off looking like a bladder, but I'm going to fan my beam down into the pelvis. And does anyone know what this is? You can either say it or type it or anything else. This round black thing. And I won't see if it's typed actually. So Myra, you'll have to tell me if anyone is brave or anyone in the conference room want to yell it out.
Alguém sabe, pessoal, dizer o que que é esse círculo preto aí que está aparecendo na imagem? Alguém quer dar um palpite? I don't think so, Renee.
Oh, okay, well, it's okay. So what do you fill your Foley balloons up with to keep them in the bladder? For our nurses, we use saline, right? So this here, this is a Foley balloon. This is what a Foley balloon looks like in a decompressed bladder. And so what I did was I started pointing straight in, and then I fanned down to this decompressed bladder with a Foley balloon in it. And then I fanned back up, and then we start to see these bowels. So see, free fluid, it's kind of doing whatever it wants. So this was a patient who had pancreatic cancer who had the Foley in, and there's ascites there. Another bonus that you can often see in our aging male population, this is a bladder with a huge prostate bulging into it. So I also have clips of a big bladder hematoma, a patient with a Foley in place with this big hematoma around it. And then we injected sterile saline and saw the bubbles, all kinds of fun stuff. But I won't torture you about the bladder anymore. I just think that there's a lot of useful stuff for bladder. Urinary retention is so common. Okay, so number 4, we're back to cardiac here. So we are trying to find our windows, and the heart is hard because we have to get in between the lung. Air is the enemy of ultrasound. We got to get between the lung and the sternum and the ribs and the liver. And so this view takes a little bit of maneuvering. So again, the liver generally comes across and it provides a window, an acoustic window for our beams to go through. So this beam here, we put it in the subxiphoid region, subcostal region, but look at how far I have to tilt it up to actually see the heart. So this is what most people, if they fail, this is why. They don't get that beam up there to the heart. So again, this is how it's our anatomy, and we're going to be there. And this is what it looks like, and I'm going to show you how to go about getting this. So the first thing we see is the liver. The liver is up at the top of the screen because it's transmitting the ultrasound beams. And then we have our patient's left and our patient's right because our marker indicators here. And so we're going to have the liver and then the right side of the heart, my right ventricle, and then my left ventricle, and my right atrium and my left atrium. And notice there's no space. It's just sitting on the liver. So now let's take this heart and stick it up there. So we've got, again, our right side of the heart, left side of the heart. And this is kind of how the ultrasound beam is because I'm slicing up. My beam is down in the abdomen, slicing up. So we're going to have, again, when we flip it back over, that turns in. So we take it from here and we flip it back up to how it looks on my screen. And we go liver, right ventricle, left ventricle. If you ever get lost here, I just stop again and I think, okay, what is my probe touching? That's what's up here and then deep. So liver, and I just know the right heart sits on the liver. So liver RV. So what Chrissy likes to do, my sonographer, and what I often will do is I point it straight down, my beam in, and then I'm gonna fan it up. So let's look at what that looks like. Beam straight in, fan it up. So we're gonna fan it up there into that chest to see the heart. So if I point straight down, I'm gonna see transverse anatomy. So I'm gonna have my liver across the top, this bright white eyebrow. This is the vertebral body. And then my aorta sits on top of it. And then I have an inferior vena cava. Sometimes we see this bowel gas. That's the stomach. So again, liver, let's get it. There we go. Liver. And then the inferior vena cava runs through the back of the liver. In a different lecture, we could talk about how to look at the inferior vena cava to see if it's flat and the patient's hypovolemic. And then we're going to see our aorta over here. And then the vertebral body with a shadow behind it. And then that stomach up there kind of, remember, air is the enemy of ultrasound. So that stomach obscures those beams. So I have found this. Now I'm going to fan my beam up into that chest wall, and we're going to see the right atrium. So again, we're going to find that cross section and fan it up. Now, sometimes my patient has a huge stomach, or maybe they are 80 pounds and their stomach is sunken in and I can't make contact. So if you have them take a nice, I say, take a gentle breath in and hold it, what happens is the diaphragm descends and the heart comes with it. This is that image of fanning up. And then I will show you on myself. I will show you my initial subxiphoid, and we'll watch what happens when I take a breath. So if your patient is awake, gentle breath in and hold it can really help bring the heart down to you. And it doesn't take me very long to look for a pericardial effusion. 2 cardiac cycles, boom, no black fluid, done. So this again, liver, right side of the heart, left side of the heart. And let's see, let's get these playing again. Oops, sorry, I guess that's just a still one there. So again, black fluid surrounding the heart here. So this is, again, the best place to find an anterior pericardial effusion. So that's what we're looking for. And then you have to be the clinician and decide if this is tamponade or fluid from something else. Or rather, how urgent is this fluid? So number 5, fifth and final, the lungs. This is the E, the extended, our extended fast exam. So again, review of the anatomy. We've got the lungs in here, and let's go through our anatomy. So we're going to go probe marker towards the head. Generally speaking, our patient is supine, and our free air is going to come to the top. If my patient were trapped face down in an earthquake, the air would rise to their back. So you actually would scan along their back. So, but we're thinking of anti-gravity. So we are not doing all the lung zones. If you learn more about lung ultrasound, these are Volpicelli zones, and this would be to fully assess for like pulmonary edema, pneumonia, etc. But because we know gravity, you really only have to, we'll kind of slide down along right here. So again, probe marker towards the head, in between the ribs. And what we're looking for, so we have skin, soft tissue. We've got those muscles. Our vessels are tucked up there. And we've got parietal pleura and visceral pleura. Normally, of course, those are intact, right? So what happens is that we actually see this sliding as my lung is expanding. And so we're getting this nice, we call it lung sliding. That's normal. So this is that pleural line. So we see rib shadow, pleural line. And I see that shimmering. Some people say ants marching. Shimmering. So this is normal. This tells me that my visceral and my parietal pleura are touching. So again, when we see it, it's totally normal. If I had a huge pleural effusion, remember, fluid's black. So I actually would see black fluid there. So normal lung sliding. So this is something here called M mode or motion mode. What it does is it is depth versus time. And so this is 5, 10, 12 centimeters. This is 5, 10, 12 centimeters. And then here we see the seconds. So this is showing us the motion over time. This first 2 centimeters is chest wall before the pleura. And I don't see any movement or granule. It's just this straight across, straight across. So this is just another way to say, I think that this is a normal lung. They call this the sandy beach sign. To me, I don't care because I have this here. I see this shimmering. Some people still like to ask for it, so I'm just teaching it to you. So what if we get this free air? I still have air under my parietal pleura, but it's not contained within the lung. And so what that means is the sliding is happening down here, but we don't have the contact. We just see parietal pleura, free air. So this is an example of the patient is trying to breathe. I see a little bit of like chest wall movement, but there's no movement here. This is just a white line. There's none of those little ants crawling or shimmering or whatever you want. This one here, this is that M mode, depth versus time, and it all looks the same. They call this the barcode sign. It's all straight across. So that's our pneumothorax. Do we have no shimmering? So like you can have movement again because your patient's breathing, the chest walls are moving, but there's no shimmering versus shimmering here. And note how when we reduced our depth to 7 centimeters, it made it prettier and clearer. So for this one, I'm going to take my depth down and really see what's happening there. This last little bit down at the base, so this is our right base. When the patient breathes, I see this come across. Air is the enemy of ultrasound. And so it's just another kind of example of there's no fluid here. I could pause and see if it's shimmering, or I mean, I could move up a rib space to see if it's shimmering as they breathe. So, okay, that was like the most whirlwind of whirlwinds ever. So I'm gonna stop. Did I just stop sharing? Yeah, I stopped sharing. I would love to do questions, and then I can show you the FAST exam with the VAVE on myself, or the EFAST rather.
Pessoal, alguém tem alguma pergunta? Vocês querem tirar dúvidas? Ela quer fazer uma demonstração nela mesma. Ela vai mostrar como que faz ali a utilização do eFast, mas ela quer saber se tem perguntas para ela. Alguma pergunta, Nelson?
Aqui no auditório não há perguntas, Mai.
Não? Ninguém enviou para você? Aqui no chat também não tem.
Não, no chat não tem, não chegou a pergunta. Só aquelas lá que foi colocado durante a semana passada, que ela já explanou todas as respostas ali, conforme a gente tinha conversado nas trocas de e-mail, né, anteriormente.
Renee, we don't have questions right now. Because Nelson asked before, when we have our first meeting, I send you some questions.
Yes, you did excellent. Thank you.
Yes, and you answered all of them during your explanation.
I forgot one thing though that was asked was about what's kind of the safety or how does this go in the ambulance. So there's little crystals in here that make the ultrasound beams, but it passes a 4-foot drop test. So to get approved, you have to show that you can drop it 4 feet and not break. Don't throw it, but they're more robust than people think. That's one thing.
Entendeu, Nelson? A questão da segurança do aparelho dentro das ambulâncias. Se ele cair, a questão é, se ele cair em cima assim do pé, ele não vai quebrar. Mas é preciso ter cuidado com o equipamento durante a utilização dele na viatura.
Não, isso sim, perfeito. Isso já tinha sido até observado. A questão agora que veio aqui conosco foi se ocorre alguma interferência na imagem durante o transporte com a ambulância sendo ligada ou até mesmo em movimento.
Para fazer o exame,
Durante o movimento.
Durante o movimento, ok. Renee, we have one question. People are asking if they can use the probe during the transport, if we have some kind of interference on the image, or if it's better if they have to use the probe, stop the ambulance, do the exam, and then continues. What's better?
I would say just keep going. Just keep going.
No interference.
No, you don't need to stop. What might make it hard would be the person. So if you're trying to ultrasound me and it's bumpy, that might make it difficult. But this is the same thing for my procedure team. I make them anchor on the patient. So if you're anchored on the patient, I'm bumping together. So no reason to have to stop.
Não tem motivos para parar. É possível fazer, só tem que tomar cuidado com o balanço da ambulância. E aí o importante é você ancorar, né? Deixar sua mão ancorada ali na localização onde você está fazendo colocando o aparelho para ver a imagem, porque aí se tiver algum solavanco, algum movimento mais brusco na ambulância, sua mão vai se mexer junto com o paciente.
Perfect. Same for cardiac arrest. People should never stop compressions longer than they have to. But this, the subxiphoid view, the compressions are up here. And so the tension here and here. And so you can do it in pulse checks if you need to, or even while it's going on.
Perfeito.
All right, so
Deu para entender? Foi?
Back on again.
Perfeito. Muito bom. Vamos para a prática.
So, Renee, they are asking if we can practice now.
Yeah, absolutely. So let's have someone there. If you want to fire up that probe and get it connected, we'll see how fast I can show you the fast exam, and then we'll have someone there can do it. So
Vocês estão conectados aí, Nelson, com o EFAST no aparelho de vocês no celular?
Nós vamos ligar eles aqui agora, ele aparelho aqui agora, e já conseguimos também tentar transmitir. Nós não temos essa qualidade de imagem a qual a doutora Renee tem de transmitir direto ali na apresentação, mas a gente consegue exportar ela aqui via câmera mesmo.
Okay, Renee, they are connecting there, the probe with the phone, and they will show the exam that they are doing there through their phone. They don't have the same technology that you have here to share.
Yeah, so
we can see, no problem.
Yeah, sounds great. So again, right side is kind of mid axillary line. And are you able to see my phone screen?
Vocês estão vendo ali o telefone dela?
Aproveita e faz uma pergunta, Mai. Se a gente consegue fazer com a qualidade da imagem sem o gel também.
Renee, they are asking if it's really must necessary to have the gel to see the image. If in some case they don't have the gel, can they see or not?
So you can use hand sanitizer, you can use lotion. It's not ideal, but my friend who taught in South Sudan one time used like canned soup. You can anything fluid.
Foi, entendeu? Pode usar até o gel, não é o ideal, mas numa situação difícil, em que você não tenha o gel apropriado, você pode utilizar o gel antisséptico.
Estão providenciando já.
So here...
Nelson, você está sem o gel aí para fazer, é isso?
Isso, estamos sem o gel, mas já estão providenciando ali um álcool em gel para estar utilizando. Mas podemos continuar, sim.
Renee, they are getting the gel there. It's the sanitizing gel because they don't have the appropriate one to use right now.
Totally fine. Sanitizer gel is great. So here I was just kind of showing the right upper quadrant real quick. No black fluid, right? So we're looking for black pointy fluid. Thankfully, no fluid. And then we'll just do left upper quadrant real quick here. So again, kind of mid-axillary line, mid to posterior, we find our kidney.
Ela foi lá pegar. Ela foi pegar. Volta aqui.
Okay, so there is that one, and there's no black fluid. And then the suprapubic, again, you just place it right over the symphysis pubis and kind of push down. I hope the break didn't ruin this. We'll see if you can see my bladder very well. Oh, I unhooked it on accident. I turned it off on accident. It'll take a second. But yeah, so definitely we'll get yours going too.
While they are taking their gel,
Yeah.
we reconnect here. No problem.
So what
Mas
I like to do is I kind of turn it on when I'm getting ready. And so if you did it in transport, again, you could get your gel, get your stuff ready and then turn on. It takes like maybe 10, 15 seconds. Okay, so we're here. So we can see the bladder is black. And so that's the bladder. There's no black fluid around the bladder. And then the subxiphoid and then the EFAS, and let's so the subxiphoid is that one where we're going to start pointing straight in and then we're going to fan it up. Okay. So I'm going, I keep hitting the button on that. So this is my my backup, not my good one. So yeah, okay, perfect. Yeah, so let's just get to you then. Let me stop. All right, so just what are we going to look for?
Qual que você tá vendo? Deixa eu ver qual que é que você tá vendo.
Vamos começar com a subchifoide, que deve ser mais fácil.
Então pega lá.
Vamos ver.
Levanta, deita ali.
Qual
Estamos avaliando
Vocês vão ver.
a subchifoide.
Agora eu vou começar.
Vou começar agora pela subchifoide.
Ok.
Então dá uma clareada.
Muda o ganho ali.
Aqui.
Okay. And where is our probe on the body? Ooh, I think I see a heart there. Are we doing a subxiphoid?
Yes, they started by the subxiphoid
Caracas, hein?
region. Yeah. Oh.
Excellent. So, oops. So let's have whomever is doing it, can they take a breath in and hold it? The model. And so it's off to the side a little bit. Are they right in the middle? There we go. There we go. Can you rock it a little bit? There we go. Increase our depth a little bit.
Ela tá para virar mais um pouquinho. Você está realmente na região ali subchifoide. O aparelho está na região subchifoide adequadamente.
E eu acho que pediu para aumentar a profundidade também da imagem. Aí eu acho que tem que ser no aplicativo.
No aplicativo, é.
And so that is
Pro outro lado,
good enough right there. So pull up and down.
isso para cima agora.
Pra cima e pra baixo. Pra cima.
Yeah, there we go. Yeah.
Posso explicar como?
There we go. Yep, a little bit more.
Vamos pra
And
cima.
so gentle breath in and hold it.
Uma
Respirar
respiração lá
devagar.
Respira devagar, vai.
e segura.
And so you don't have to have a perfect image to make a decision. If this patient has a blood pressure of 60 over 30 and you don't see black fluid right there, do you think it would be a big enough pericardial effusion to cause that? Like, no.
No.
So we don't have to get perfect images to have them be useful.
Pegou?
And then do you all want to try, here's just like our lung sliding. Do you want to try like a bladder or a right upper quadrant, maybe a nice Morrison's pouch?
Deixa eu fazer.
Deixa eu
Quer fazer?
Deita ali,
Aonde
deixa eu
vocês vão fazer agora, Nelson?
Deita.
Tenta uma outra região.
Tá, sim. Qual que vai fazer?
Desconectou.
Pode, desconectou, peraí. Play slides. Peraí que desconectou aqui. Qual hora que você vai fazer?
Conectou?
Não. O
A internet que tá mais.
que você vai fazer?
É para agora.
So was sometimes so what we do. Oh, nice, the model down there. Okay. Enthusiastic. I hope the floor is pretty clean.
Você tem que ligar de volta.
They are connecting there. I think that they lost the connection.
Agora que é isso, vai ficar verde. Quando ficar verde, tá ligado.
Ainda bem que não ia com transvagem, não.
Eu não posso rir, sabe? Não, ainda não.
Nelson, quando estiver conectado aí, você avisa.
So a couple of troubleshooting.
Agora.
Okay.
É. Espera que perdi de novo. Vem, conectando, conectado.
Isso é verde, apareceu lá, ó. Você não vai aparecer tocando porque você é verde.
There we go. Okay. So which what are we gonna, I can actually see it perfect. Yeah. So what are we gonna try to do? Let's do a Morrison's pouch maybe, or whatever they wanted to do. I'll guess based on what we're seeing.
Consegue aproximar um pouquinho a câmera? A imagem não está muito boa. E um pouquinho mais para cima. Aí, agora sim, tá melhor.
So I guess it looks like I'm seeing like air, I think, right now. It's hard to say. So tell me where the probe is. Oh, I just saw something.
Bote a sonda no.
So let's slide a little bit towards the patient's back. I think I see a kidney up there in the top right, maybe. And is that where they are?
Aqui, ó. Deixa eu ver aqui. Peraí, eu já tô vendo. Eu quero acender aqui, ó. Tô dando um bug.
So fun. Okay. Perfect. So I want the probe indicator towards the patient's head, and let's slide a little bit more towards the head. So slide, grab a little more gel, and then maybe slide like 3 centimeters towards the head. Oh, there's the kidney right there. Excellent. So we could reduce our depth a little bit. So pull down on the screen a little bit.
Reduz um pouquinho a profundidade.
Great. And then release it. Excellent. That's the kidney. That looks like a peanut M&M. So we would look for black fluid surrounding it. One thing, Nelson, that would help, bottom left, see the little heart? I want you to tap on the heart and then tap on the liver, because that's going to make a better image for us. So on his phone screen, if you can turn it around, tap the heart and then tap, yeah. Because his phone controls it.
Nelson, na tela do seu fone tem um coraçãozinho que você pode clicar. E aí você clica no coração e no rim.
Excellent. Now it's going to give us a better image when they get back on there. And you can just, just wait and let's see what we see. Okay, so that looks like kind of maybe bowel. There we go. Beautiful. So see that we've got a liver, and then see the bright white on the right-hand side? That's air. Air is the enemy of ultrasound. That's probably the colon. So can you fan your beam towards the patient's back a little bit to try to get away from that air? So the person with the ultrasound, there you go. Yeah, great. Okay. So now have our patient breathe in. Can we do that? Excellent. So there's a kidney there. And then big breath in from our patient. Let's see if we can make the diaphragm come down. Big breath in. Yeah, so we're right there and we can see up the little liver tip. So why don't you all, can you hit the little record button to prove your first beautiful inferior liver tip? I mean, we're recording the whole thing anyway, but that right there, that is a clinically useful image.
Faz uma foto, Nelson, e clique rápido, pequeno do vídeo para fazer uma gravação.
Acho que ele acabou de gravar aí, deu para ver.
Foi?
Yeah, I think it went.
Beautiful. Inferior liver tip, you've got Morrison's pouch. There's no black fluid. So the only thing is, if I wanted to say there's no hemothorax, where would they have to move the probe to show me the pleural space? Let's ask them that. So let's slide our probe towards the head. I want to get up to that pleural space.
Ela quer chegar no espaço pleural.
Okay, we're getting closer.
Tá chegando, tá se aproximando.
So now, okay, beautiful. So let's have our patient. Can our model take just a really big breath?
Respira fundo.
Beautiful. See, there's no black fluid above the diaphragm. And so the little freeze button, when Nelson hits the freeze button, you can rewind it for like 120 still images, versus the little record button at the bottom right takes a prospective clip. Beautiful. Yeah, so this is so great. Okay, so in this right upper quadrant, there is no free fluid and no hemothorax. Or sorry, no, whatever. You know what I mean. Should we try the left upper quadrant? It's a little harder, but you're doing great.
Vou tentar o outro quadrante agora. O quadrante superior esquerdo.
O quarto ainda, né?
Ela falou que vocês estão indo bem, viu?
Quem quiser vir praticar, vir para frente aqui, pode vir aqui. Vem aqui também.
Estou torcendo para não ter nada.
Ela só não chama de foto. É que ele tá evaporando, né? O que está acontecendo? Posso passar? Dela mais uma foto atrás.
Okay, beautiful. So, looks like
É mais para trás, ó. Bem lá para trás e é mais posterior para cima.
okay, that almost looked like a kidney there for a minute. Yes, there's a kidney.
Que lá tá ruim de ver.
So I think, Nelson, I want you to make it a little, I want the gain to go down a little bit. So Nelson's gonna move the gain a little bit lower.
Só vai ganho positivo, tá ok.
Just so, like, Nelson's gonna put his finger on and move it like 1 centimeter to his right.
Esquerda, isso. Ou sua direita, isso.
His right. Yes, excellent. Thank you. Thank you. Great. Okay. So I'm trying to see what we're seeing. Actually, let me see if I can make this bigger. My face is bigger. I don't need to see my face.
Chega um pouquinho mais próximo, Nelson.
There we go. Okay. All right. So I think I see a kidney there. Let's have our patient take a breath in.
Vamos lá, vamos ver se consegue mexendo.
Respira fundo.
Puxa fundo o ar lá, doutor.
There we go. And so for a second, we started to see that spleen. And just to make sure, their probe indicator is towards the patient's head, correct?
Perfeito.
A sonda está voltada para a cabeça do paciente. Agora foi.
Está. Sim.
Okay.
Yeah,
So that, I think that's a little psoas muscle. Okay. Why don't we do this? So they're going to slide a little bit towards the front of the patient and then fan their beam a little bit towards the back of the patient.
Só depois do paciente. Sobe pouquinho o som.
Really close, I think. Okay.
Nelson, pode explicar de novo.
And about how high are they on the patient?
Ela quer na linha entre lá abaixo assim.
Like maybe like xiphoid process height?
Só pergunta a altura.
Pergunta lá, mas se é para mudar então na imagem pulmonar, coloca o pulmãozinho ali.
Que altura que vocês estão agora? Tá na altura da...
Agora está na altura patorrenal. Ali.
Oh, and you know what? That preset at the bottom left, it looks like the lung, not the liver. Can we make that preset the liver?
Isso, fala para ela que nós estamos agora próximo vendo pulmão e o fígado. É essa mesma área.
They are near the lung and the liver.
Yeah, so the little button at the bottom left that shows a little pair of lungs, can we have Nelson tap that and tap on the liver? It will make the image better. I think we accidentally changed our exam type again.
É a imagem, Nelson, para você clicar no pulmãozinho, porque aí vai ficar melhor de visualizar.
Eu já tinha clicado no pulmão.
Okay, so is it on the little liver?
Aqui.
Tem que colocar no liver. Trocar do
liver, desculpa, no fígado.
Yeah, the one right below. Yep, that one.
Yeah.
Excellent. This will be a prettier image for them, I promise.
Aí mesmo.
Okay, so let's so if we're right here in our
olha onde é que ela está pedindo ali, ó. Aqui, ó. Mais para cima um pouco.
Right here. There we go. You see the spleen up top there? Up at the very, very top is the spleen and the kidney. So as they bring their beam towards the back, beautiful, beautiful. Yes. So see that? So it's kidney, spleen, diaphragm, no black fluid between the kidney, the spleen, the diaphragm, and no black fluid above the diaphragm.
Tá vendo ali, ó? Dá para ver tudo ali.
Awesome. A little darker, actually. There you go. Much better.
Oh, very nice.
Okay, beautiful. Should we try a bladder?
Agora tentar a bexiga.
Nelson's getting really good at sliding backwards. Without looking at the
Oh, boom. That's it. You got it. That's the bladder. Beautiful. So we would make it a little bit darker so that we didn't miss fluid back there. But we don't see any fluid outside of the bladder.
O som tem que virar para cima, assim, isso, assim.
Não, a parte da setinha.
Só que tem que ficar mais em pé, isso, assim mesmo.
And then I love it. So you rotated probe marker towards the head. See that bowel? You can see peristalsis there on the right.
Assim, do jeito que tá agora. Boa. Assim.
Killing it. Okay, so the last thing we have to do is to find the lung sliding, and you will have done your first EFAST. This is so exciting.
Agora só falta os pulmões.
Yep, perfect. So you can leave it in abdomen or you can do lung. You're totally good. And then let's reduce our depth to like 6 centimeters. So can you slide down to make it more shallow?
Já mexi. Tem que colocar para poder reduzir.
Isso, acho que está em 12 agora. Se você ir até 6, Nelson.
Seis. Ok.
Perfect. Okay, so put it up. Beautiful. That's it right there. Okay, and see the little shimmering,
Excelente.
shimmering.
Respira, respira. Respira.
Amazing. And that's, so if you wanted to do that seashore sign, what we would do is we would hit modes. So it goes, there's a little lung, and then just to the side of it is a little, oh, I think, did they just freeze?
Yeah, I think so.
Yeah. But that's how they would do M mode, but they just got a full EFAS. That's amazing. Quick learners, goodness.
I think we lost them a little bit. And Renee, if you wanna, if you
I'm
click
sending,
on,
yeah, I'm sending him
oh,
a
go ahead,
message.
Myra.
Yeah, just to understand what happened there.
Yeah, perfect. So my thoughts in follow-up. So my friend Gregor, again, the one who's the pre-hospital medicine doc in Slovenia, he's got some cool cases. So it'd be fun to see if we could do a little case session. If folks are interested and want to practice in person, I could see if some of my Brazilian contacts could help out. Again, the one is just like an hour flight south. So I'm happy to help facilitate whatever.
I think that's a very good idea, and Nelson can see how we can do that. So if it's interesting for them to have this in person, I think yes, but he needs to talk to us about the strategies for that.
Of course, yeah. So
it would be wonderful.
Cool. Well, this was exciting. I'm so glad they got awesome images.
So it's working today.
Yeah, you all crushed it.
Oh my God. Let me call him and see what is happening there. I don't know if it is the internet, the signal of the internet or something like that, probably.
Yeah. Well, and I'm happy. Again, I could tag team with my friend Gregor if we wanted to do, if someone can bring a Mac and a cord, I can help them screen share just like I did for you. So we could do more teaching that way too.
Oh, great.
Yeah.
And Renee, quickly, when they come back, if you click on the peoples on the right side of the Google Meet, you can pin their own screen so you can see it bigger.
Yeah, I did figure out. So I am, let me.
You're still larger than anyone else here because I think you're the presenter. You're pinned for everyone.
Got it. Okay, yeah, I did pin him bigger.
Right.
So my I do have my in-laws coming over for dinner in a little bit, so I'm gonna have to run in not too long, but.
Renee, I think that it's his battery because I'm sending messages.
Yeah, he probably.
And he's not answering, and I call it, and this is on the post. Oh, I forgot in English.
Português, como é que
é? Caixa postal. Esqueci.
It's getting into his voicemail, Renee.
Voicemail, yes. So
yes.
I think it is his battery. Something happened with them. So, but here, who is online? Oh, Fran is here. Fran.
Yeah.
What happened there?
Fran, você tá no mudo, Fran.
Nós vamos só mudar o computador aqui.
Acabou.
Deu problema na conexão.
Deu problema na conexão ali, mas já voltamos aqui. Cadê o aparelho? Papel solido. Libera para nós. É esse?
Só puxar. Ah, é que tava no teu celular?
Não, tá no telefone dela. Tem que ligar, desligar e ligar de novo.
Ele tá desligado, acho. Quando ele para 10 segundos, ele desliga.
Well, you all crossed your first EFAST. It was fabulous.
Ah, voltou.
So again, I'm happy to do a follow-up virtual teaching. Hook up my friend. Okay, perfect. Let's get one more lung zone, and then I have to go make dinner for my in-laws, like I said. So I promised them that.
Nelson, ela disse que vai ter que cozinhar para os sogros que estão chegando na casa dela daqui a pouquinho. Você tá no mudo. Só
Para fazer só a parte agora dos pulmões, né? Faz só a região ali do pulmão e aí ela vai precisar sair.
Não tem problema, até mesmo porque o telefone aqui tá com a... Não tá conectando.
Mas ela falou também, Nelson, que ela tem um amigo que tem alguns casos, algumas sessões clínicas, que se vocês quiserem, ela pode fazer a conexão entre vocês, e mesmo que virtualmente, ou até mesmo pessoalmente, que é uma questão de conversar e ver as possibilidades para um futuro encontro.
E tem uma médica que ela trabalhou no passado brasileira que fica em Porto Alegre. Então, seria um pulinho rápido de chegar aí.
Fica mais fácil da gente trazer, então, caso ocorra algo presencial, então. Boa, vamos tentar engatilhar isso.
É uma possibilidade.
Exato.
Vocês vão conseguir, Nelson, fazer a parte do pulmão ali ou não conseguem? Você tá no...
They're reconnecting the probe. Yeah.
Okay, and then for them to know troubleshooting wise.
Legal, okay.
Right. It's an app just like anything else. And so if you have like 10 things open, it's all using data. So sometimes killing your other apps. And then, okay, but excellent. Well, there we're on and if you ever have a connection issue, it's just like when my navigation app acts up, I just kill it and reopen it. Perfect. So let's reduce our depth. Let's make it more shallow so I can see that shimmering. There you go. Keep going. I want to see that shimmer. Beautiful. So I see that shimmering there.
Mm-hmm.
And then, so what I want to do is let's hit the button just to the right of the lungs. It says modes. And then hit M mode. Perfect. Yes. So you just have to slightly move it a tiny bit and then it will go. So just kind of like put your finger on it and like tap it, the line. There you go. And then you can release it. Beautiful. So they're going to hold nice and still. And the top is that linear and then the bottom is the sandy. Yes. So we hold nice and still though. Otherwise we're seeing motion everywhere.
Tem que segurar a probe bem parada.
And there's that. So kind of that sandy is there. But again, if I see that shimmering, I don't care. I don't bother with this. So. Excellent. Yeah. So you did it. You all did it.
Vocês conseguiram.
Yes.
So let's definitely we can do a virtual practice session and I'll tell them how to plug in the phone like I did. And then we'll get Gregor to do some cases, some pre-hospital ambulance cases. Okay. And then we'll see if they're interested, we can see if Dr. Tonelli can come visit.
Ele não faz doutor.
Perfect.
Faz?
Mike.
Wait.
Surgiu uma dúvida aqui, ele faz Doppler?
Renee, they are asking if this probe makes Doppler.
It does color Doppler, yes. It's not great color Doppler yet, but it does color, and we're working on making it better.
Ele faz, não é perfeito ainda, mas ele trabalha com cores. Eles estão trabalhando para melhorar essa função do país.
Tá. Mas e daí, qual das áreas ali a gente acaba utilizando? Pulmonar, renal ou a cardíaca?
In which area they can do the Doppler, Renee?
The little liver one or the heart one? So abdomen or heart, both will have color.
No coração e no liver and heart?
Yeah, the abdominal and heart.
Certo. Perfeito.
Good.
Excellent. Okay, well, thank you. This has been, you all are fabulous. I mean, I'm really impressed with those images you got. I mean, that was, or I could say I'm impressed with my lecture, but I'm actually impressed with you all.
Eu acho que só nós mesmos temos a agradecer por essa bela troca de conteúdo a qual tivemos aí nessa noite de hoje, né, que vários profissionais passaram pela sala. Ao meu contar ali, na sala, mais ou menos, passaram mais de 40 pessoas entre e sai. Foi uma troca muito importante para todos os nossos serviços do SAMU de Curitiba e Região Metropolitana. Muito obrigado, doutora Renee. Doutor Cadenas, uma palavra?
Just a second, just for Renee understand. Renee, he said that he's very happy. We had during this night 45, 46 participants here today during the meeting. So we are very happy about the contribution that we have with you this night.
Thank you.
Cadenas, would you like to talk something? Você gostaria de falar alguma coisa, Cadenas?
Sim. Congratulations, doutora Renee. Parabéns pela didática e pela clareza da apresentação. Tenho certeza que muito rico para todos nós e agradecemos imensamente a disponibilidade de tempo sua e a dedicação em preparar esse material tão rico para nós. Obrigado, Nelson, pela organização. Obrigado, Fran, pela disponibilidade aí para a gente poder trazer para as nossas equipes esse conteúdo.
Obrigado, Mai, também, né, por estar aí traduzindo para nós aí direto do Rio de Janeiro, fazendo tradução simultânea. Agradecido.
Imagina, eu que agradeço a oportunidade. Renee, they are very thankful about your class, your, how can I say, didactics that you had today. We could make it works even with you in the United States. Here, I'm in Rio, they are in Curitiba. So it was wonderful, a very good experience with the virtual class, and everybody is really, really happy with the experience. So thank you very much. It was wonderful.
Yes, well, hooray. We'll hope to do more follow-ups and get you all going.
Ok. Ela vai continuar acompanhando vocês, Nelson, caso precise algum outro contato, se precisar trazer o médico aqui para fazer o médico conhecido dela de Porto Alegre para fazer alguma sessão presencial de casos clínicos com vocês, é possível também. É só uma questão da gente conversar e ver as oportunidades.
Agora eu tenho o WhatsApp dela.
He said that he has your WhatsApp.
Yes, he does. Totally. Yeah. Send me images.
Mai, agradece ela também em nome da Aramed aqui, que a gente vai iniciar um trabalho. Eu acho que é um início de um grande trabalho nessa área de urgência e emergência, e é um dos primeiros passos, e a gente vai estar deixando com a equipe aí para eles colocarem em prática lá dentro das ambulâncias, porque é um grande trabalho que a gente pretende estar realizando aqui na região com o Ultrassom, que hoje não é tão difundido, né, nessa parte de urgência e emergência, e a gente quer abrir esse canal aqui também dentro do Brasil e da nossa região. Obrigada, doutora Renee.
Renee, Fran is saying that this is the first time that we are using the eFast here in Brazil. So they are the beginners it's not something very useful here yet. So they want to make it work here in Brazil. So they're going to start with the probe at the ambulances. Quando que vocês vão começar, Renê?
Eu acredito que segunda ou terça-feira a gente já vai deixar esse aparelho em uma das 4 bases nossas. Eu vou sortear ali junto com o Dr. Cadenas qual vai ser a base que vai permanecer lá uma semana.
Okay. They will put send the probe to their services on the next week, and start this. This is the first step, actually, to make them useful, and one of the first services here in Brazil that will use this at the emergency and at ambulances. So they are very happy.
I love it. Well, happy to help. However,
Que bom.
Eu fico feliz em ajudar e vamos em frente.
Tchau, muito obrigado a todos por terem participado. Ficamos bem felizes aí de ter podido ter tido seu tempo com vocês aí. Em breve, estamos nas bases aí, passando um pouquinho mais do conteúdo para vocês. Um abraço, uma boa noite a todos. Obrigado, doutora Renee, obrigado, doutor Cadenas. Mayara, muito obrigado aí pela enorme colaboração que você nos deu nessa noite incrível.
Eu que agradeço, pessoal.
E obrigado, Fran, também, por estar ajudando a gente nesse momento incrível aí.
So, Renee, Diego, Cadenas, thank you so much. Aramed, thank you so much for this night. And for all of the participants
Thank you very much.
Here with us this
Obrigado,
night.
pessoal.
Thank you.
you all did great.
Bye. Bye, Renee. Thank you so much.